Many thanks for this opportunity to present some of our work in the iBRA, Pre-bra, Anthem and TeAm studies that aim to generate the evidence for oncoplastic and reconstructive breast surgery. We perform oncoplastic and reconstructive breast surgery to improve outcomes for our patients, but there really is very limited evidence to support the benefits of many of these techniques. We initially wanted to focus on generating evidence for implant-based reconstruction, and this was the point of the iBRA and the Pre-bra studies. The design for iBRA was born when we wanted to design a randomized trial evaluating new approaches to implant reconstruction, but it quickly became apparent we didn't know what comparators to use, what meshes we should be using, if any, or what outcomes we should measure. So we designed iBRA, which was a 4-phase trainee collaborative-led study. Phase 1 was a national practice survey that demonstrated huge variation in practice. Phase 2 was a large multi-centre prospective cohort study for consecutive women undergoing implant reconstruction at different centres, collecting clinical and patient-reported outcomes. Phase 3 was an RCT acceptability study, and this led to Phase 4, which is the design of the full-scale RCT. We use quality standards from the UK ABS and BAPRAS oncoplastic guidelines. These were mainly implant loss, which should be less than 5% at 3 months, unplanned return to theatre, unplanned readmission, and infection. And we also wanted to assess satisfaction with outcome at 18 months. iBRA was a trainee collaborative-led study, and despite some initial reservations, iBRA recruited above and beyond what we could have expected, with a total of 2,108 patients ultimately recruited from 81 centres across the UK between July 2014 and June 2016. This table summarises the demographics of patients in the iBRA study. This is pretty much what you would expect for women having implant reconstruction. Of note, however, approximately 10% were smokers, and just under 7% had previous radiotherapy, which would be considered risk factors for complications. This pie chart summarises the types of implant reconstruction performed within the iBRA study. Most notably, over a half of patients in the study had subpectoral implant reconstruction with mesh, 20% had a dermal sling, only 11% had synthetic mesh, and notably less than 10% had standard 2-stage expander implant reconstruction. Pre-pectoral reconstruction only accounted for 2% of patients within the iBRA cohort. Interestingly, 14 different types of meshes were used throughout the iBRA period, with the number increasing towards the end of the study period. This table summarises the outcomes in the iBRA study in comparison with the outcomes from the original National Mastectomy and Breast Reconstruction Audit and the quality criteria from the oncoplastic guidelines. As you can see, there's been very little improvement in outcomes in iBRA compared with the National Mastectomy Audit, and notably, the unplanned return to theatre has increased by more than 3-fold, suggesting that although we are managing these women more aggressively, we are not improving key outcomes such as implant loss. There was also significant variability in the key outcomes. This chart summarises implant loss by participating centre, and this is for centres recruiting more than 10 patients to the study. As you can see, at one end you have centres with no implant loss, but at the other end you have centres in whom approximately a third of patients lose their implant, and this degree of variation is completely unacceptable. So we've used the iBRA data to investigate best practice. So things that don't matter or don't seem to matter in iBRA was the use of laminar flow, whether you wash the pocket, whether you do sentinel node or clearance, what type of skin prep you use, or where you put your incision. The things that do matter are operative time, use of extended antibiotics before 24 hours, and there's some suggestion that implant size might be important. This reinforces the fact that for implant reconstruction, patient selection is really, really key. Risk factors for complications in iBRA were smoking. Smoking increased the odds of implant loss by almost 2-fold. BMI significantly increased the risk of complications. Operative time and previous radiotherapy were all important. One thing that didn't affect complications was the type of mesh used or the position of the implant. We also looked at patient-reported outcomes at 18 months, and this chart summarises the domains of the breast Q, satisfaction with breast, satisfaction with outcome, psychosocial wellbeing and physical wellbeing by the different types of reconstruction, submuscular in red, biological in green, synthetic in blue, dermal sling in yellow, and pre-pectoral in purple. The use or type of mesh did not appear to impact patient-reported outcomes at 18 months in subpectoral reconstruction, but there was some suggestion that pre-pectoral reconstruction did increase satisfaction. The minimum clinically important difference for the breast Q that's recently been published is 4, and our analysis suggested there was a 6.6 point difference in satisfaction with breasts in women having pre-pec. However, there were only 14 women who completed patient-reported outcomes who had had pre-pec reconstruction, and only a small number of expert centres were performing pre-pectoral reconstruction during the iBRA period. So this may be a chance finding, and further research is needed. And for this reason, we designed the Pre-BRA study, which is an ideal 2A, 2B prospective cohort study to determine the safety and effectiveness of pre-pectoral implant reconstruction. Unlike iBRA, this was a formal research study supported by the NIHR and portfolio adopted, and was one of the first iBRA-Net studies. The aims of Pre-BRA were to establish the short-term safety of pre-pectoral reconstruction using different meshes, and the primary outcome was implant loss at 3 months. We wanted to explore effectiveness at 18 months with pain scores and patient-reported outcomes, including the newly developed animation module of the breast Q. We wanted to determine whether the technique was stable and ready to be evaluated in a trial, and we wanted to build a network of surgeons performing pre-pectoral reconstruction to a high standard who would be willing to participate in a future trial. The Pre-BRA study started off very well. As you can see, the predicted recruitment is in green and the actual recruitment is in purple. We consistently recruited above our recruitment target until COVID, where we had to pause the study for 6 months. We were then able to successfully restart and recruited our target of 341 patients by the end of December last year. This table summarises the patient demographics of patients in the Pre-BRA study compared with those in iBRA, and they are strikingly similar. There's a slightly increased number of smokers, but the other demographics are broadly comparable. In terms of the type of mesh used in iBRA and Pre-BRA, Pre-BRA meshes are shown in orange and iBRA meshes are shown in blue. There's a far higher proportion of biological mesh in Pre-BRA, with almost all patients having a biological mesh-assisted procedure with very little synthetic mesh used. And more than 50% of the biologicals were Braxon, with 1 in 3 being SurgiMend. So how do the outcomes in the Pre-BRA study compare with those in iBRA? Well, this table summarises the outcomes in Pre-BRA compared with iBRA in the National Mastectomy Audit. And the most striking thing about this is how similar all of the outcomes are. There's a slightly lower incidence of infection in the Pre-BRA cohort, but this may reflect the way that data was collected, that unplanned return to theatre, readmission, and implant loss are broadly comparable across the 2 studies. So these data support the fact that an RCT and implant reconstruction may indeed be possible, and in fact could arguably essential to support best practice. And we're delighted to say that the BEST-BRA study, which is a UK external randomised pilot feasibility study, is currently open and will explore whether it's possible to recruit patients to a study comparing the clinical and patient-reported outcomes of pre- and subpectoral reconstruction. And this is one of 7 international studies currently exploring this research question. Now we'll move on to the TeAm study, which was an international audit of the practice and outcomes of therapeutic mammoplasty. We wanted to look at who was doing therapeutic mammoplasty, how many units were doing it, what the complications were, what the re-excision rates were, and whether therapeutic mammoplasty impacted the use of adjuvant therapy. We recruited consecutive patients undergoing therapeutic mammoplasty for 10 months between the 1st of September 2016 and the 30th of June 2017. We defined therapeutic mammoplasty as the oncoplastic application of reductional mastopexy techniques, including the removal of skin, to reduce the skin envelope, to remove cancer or DCIS. We included patients having wise patterns, vertical scars, Benelli or round blocks, rackets, Grisottis, and with or without nipple preservation. We didn't include standard wide local excisions or volume replacement. or any patients having surgery other than for cancer or pre-invasive disease. Our audit standards were the oncoplastic guidelines for best practice and the current NICE guidelines, with the primary outcome being reoperation for complications at 30 days. We recruited 880 patients from 50 centres. The median age was 56. The BMI was fairly high at 28, and there were 10% of smokers. Interestingly, there's a fairly even distribution between symptomatic and screen detected disease, and a fairly even spread, with most cancers being in the upper outer quadrant. The median lesion size was 24 millimetres, but this ranged from 2 to 120 millimetres. There was a variety of different incision patterns used, most commonly a wise pattern or inverted T, with almost half of cases, but about 25% included Benelli type procedures, with smaller numbers having vertical scars and other approaches. This table summarises the surgical complications in patients having therapeutic mammoplasty and those having contralateral reduction mammoplasty. The overall complications were approximately 20% in the therapeutic mammoplasty group and 14% in the reduction group, but overall the complications were fairly low. The return to theatre rate overall was 2.8%, and the return to theatre rate was similarly low, and this is well lower than the standards. Risk factors for complications, as one might expect, included smoking, obesity, surgical experience, wise pattern, and operative time, but having bilateral surgery did not impact complications in the TeAm study. We looked at the success of oncoplastic breast conservation in the study, and over 80% of patients in TeAm had clear margins at the first operation. For those patients who had positive margins, approximately half of those went on to successful re-excision. 6% had a completion mastectomy following chemotherapy, and a further third had a completion mastectomy. Overall, the rate of successful breast conserving surgery in patients having oncoplastic breast conserving surgery in TeAm was over 90%, with a mastectomy rate at just about 6%, which is fantastic, as many of these women would not be suitable for immediate reconstruction given their comorbidities and high BMIs. Risk factors for incomplete excision were preoperative tumour size and multifocality, but none of the other factors we investigated were shown to be associated with positive margins. Time to adjuvant therapy was available in the majority of patients, as the majority required at least radiotherapy. The median time was 54 days. This table summarises the TeAm data in comparison with the data from the iBRA study, which looked at time to adjuvant therapy in patients having mastectomy with or without immediate reconstruction. And as you can see, there's no clinically significant difference in the time to adjuvant therapy between the patient groups. TeAm was fantastic at establishing what was going on and what the complications of therapeutic mammoplasty were, but it didn't include patient-reported outcomes or cost, and didn't directly compare therapeutic mammoplasty with mastectomy or immediate reconstruction. So we therefore designed the Anthem study, which is a feasibility study determining whether it's possible to identify women suitable for oncoplastic breast conservation as an alternative to mastectomy with or without reconstruction, and offered both procedures. Anthem again has 4 phases: a national practice questionnaire to explore current practice, and prospective multicentre cohort study. It also has embedded qualitative research to explore why women decided to have oncoplastic breast conservation or mastectomy, what they thought of the outcome, and also what they think of the patient-reported outcome tools, notably the BreastQ, that we are using to assess the outcomes. And we're hoping to use these data to design a large-scale study. So how are we getting on? Well, so far we have national practice questionnaire data from over 54 units, and it demonstrates huge variation in terms of approach to multifocality, symmetrization, but it also demonstrated a large number of units interested in recruiting to the cohort study. Anthem has been similarly impacted by COVID. We opened to recruitment in December last year, but things have been quite slow. We've got 19 units currently open, of whom 10 have actively recruited, and 79 patients have been recruited so far. We're hoping to recruit until June 2022, and the current aim is to recruit as many patients as we possibly can within that time. So watch this space. We should have some good quality comparative data comparing oncoplastic breast conservation with mastectomy, and we'll determine whether a large-scale study is possible. So in summary, all of these studies together are generating the evidence for oncoplastic and reconstructive surgery, and this is benefiting patients and the NHS, and evidence-based surgery is coming and possible. I'd like to thank all of the people who recruited patients to iBRA and all of the people who recruited patients to TeAm, because all of these studies are a collaborative effort, and it would not be possible without everyone who participated. If anyone has any questions, I'm very happy for people to email me. But this work shows that collaboration and working together really is the way to establish an evidence base for surgery. Thank you very much.